I would like to announce that this is the inaugural event of our Winning the War on Cancer project and campaign. And this is the first of the series, and when I talked to Dr. Barloghi about it, I said, we would like to do something like that. He said, bring it on. I knew that this guy will never decline to take a challenge. Dr. Barloghi is known to all of you. It's known to me, actually he's known to me before even I got here. When I got here for a year and a half, I would go around and I would not see Dr. Barloghi. I did not know who he was, and nor did I know how he looked like. And one day I asked, but how did Dr. Barloghi look like? I said, you don't know? You have never seen him? Don't you know that guy who comes in the leather suit and the motorcycle helmet? I said, is that him? They said, yes, that's him. I said, okay, I know him now. So from then on, we started really actually, one day he called me and I came and we worked on many difficult cases, and since then we have not stopped. But I did not have the honor and privilege to work with him and under his guidance. But I can tell you that without Dr. Barloghi, the Arkansas place would be completely different. And we are very proud and happy to have him and have continued presence here indefinitely. So that's number one. On the other hand, when we thought of who would be a good challenger, we kind of ran different names around here, and I talked to Dr. Barloghi and said, let's invite Dr. Rajkumar. We had difficulties to overcome, most importantly, traveling. And when you look at his CV, he's an outstanding, accomplished scientist and physician. Not only he has published hundreds of original manuscripts and hundreds of reviews and hundreds of book chapters, he had the time to sit at so many committees that I could not even count. When I saw him this morning, I said, you looked and sounded bigger to me. Have you lost weight? He said, no, that's me. With this, I want to introduce, this is like short introduction. I want to walk you through what we are going to accomplish today. Today is going to be the inaugural Controversies in Oncology series, and it's going to be about the topic, is myeloma curable? This is the plan of what we are going to do. We went through some negotiations about what to do. It wasn't really as hard as for presidential debates, but we had to fine-tune it to satisfy everybody. And I think we found that this is the nicest formula. I will present the case, I will ask you to vote, and then Dr. Barloghi presents his argument, Dr. Rajkumar presents his counter-argument. There will be an open debate for about 15 minutes, and we will revisit the case, and I will ask you to vote again to see who won this debate. There will be an open question and answer for the audience, and we will conclude. Without any further delay, I'm going to go to the case. This is a 64-year-old man with past medical history of diabetes and multiple DVTs. He was diagnosed with the smoldering asymptomatic multiple myeloma on a routine annual examination. 6 months later, the patient presents to the clinic with back pain and recent weight loss. Laboratory analysis indicated moderate anemia with a hemoglobin level of 8.9, creatinine 3 milligram per deciliter, calcium 12.5, beta-2 microglobulin 4 milligram per liter, and albumin 3.4 gram per deciliter. Serum electrophoresis showed an immunoglobulin G kappa M spike of 7.6 gram per deciliter and free kappa light chain 110 milligram per deciliter. Urine monoclonal protein was 3 gram a day. PET scan, we ordered PET scan, showed 10 focal lesions, and the skeletal survey showed multiple smolytic lesions. A bone marrow aspirate and biopsy revealed 60% monoclonal plasma cell infiltration. Cytogenetic analysis revealed chromosome 13q and 17p deletions. Based on these findings, the patients meet the indications for treatment. And the first question to you, which of the following initial treatment strategies is optimal for this patient? Let me read them. Number one is late transplantation. You start with initial treatment with non-melphalan prednisone regimen followed by maintenance therapy. The second one, you don't do transplantation, you do only chemo or other agents. Early transplantation without maintenance, early transplantation with maintenance, and early transplantation with tandem transplantation and maintenance. So who will vote for late transplantation? Raise your hands. Nobody. No transplantation at all. Early transplantation without maintenance. Nobody wants to vote for it. Then early with maintenance. Anybody? Yeah, I see a few hands. How about the tandem transplantation with maintenance? I see a few hands. Okay, good. Thank you. And now, if you have to choose a regimen, which regimen you would choose? Bortezomib, thalidomide, dexamethasone, or number 2, lenalidomide, dexamethasone, or bortezomib, melphalan, prednisone, or bortezomib, thalidomide, dexamethasone, and adriamycin, cytoxan, etoposide. Who votes for number 1? VTD? Nobody. RD? Nobody. 1. Dr. Safar? Okay. For the VMP, bortezomib, melphalan, prednisone. Anybody? None. And the last one, VTD ACE. All of us. All right. Now, you expect then the cure rate in this case to be, you tell me, 50%, 75, 85, 90, or cure is not possible. Who votes for number 1? Number 2? Number 3? 4? Number 5, cure is not possible. I'm kind of equal here. Now let's go to multiple myeloma. Do you think that multiple myeloma is curable? And if it is, what is all comers here? 50? Who votes for 50? 75? 85? We have 2, 2, 1. 90? And cure is not possible for multiple myeloma.
How about 30?
30? Anybody for 30? If we lower the bar low enough, you know, anybody can get it, Dr. Barloghi. Okay, I'm going to stop here and would allow first Dr. Barloghi to present his argument.